Hello, and welcome to our University of Wisconsin School of Nursing Roundtable Red Talk. Symptom science and palliative care is one of our signature research areas at the School of Nursing, and we have 4 School of Nursing faculty members here today to discuss emerging research opportunities and challenges in symptom science and palliative care. Our research programs are diverse, but we all share the goal of reducing patient suffering in the context of acute and chronic life-threatening illness. Let's meet the panel. I'm Chris Queckaboom. I've been a nurse scientist for 25 years. 20 of those have been here as a professor at the University of Wisconsin-Madison, and my program of research focuses on symptom self-management in adults living with cancer. Dr. Montgomery, would you like to introduce yourself?
Yes, thanks. I'm Dr. Montgomery. I'm an assistant professor, and my research program focuses on symptom assessment and management in children and adolescents living with cancer.
Next, we have Dr. Pekanik.
Hi, I'm Dr. Pekanik. I'm an associate professor. My program of research focuses on communication during treatment decision-making.
And finally, Dr. Miller.
Hi, I'm Dr. Miller. I am an assistant professor, and my program of research focuses on examining the spiritual dimension of health and well-being in the context of serious illness.
Well, thank you all for joining me today. Let's kick off our discussion by learning a bit more about each of your areas of research. And specifically, could you each share how your work addresses suffering in people facing acute or chronic illness? Dr. Miller, would you like to go first?
Yes, thank you. So my interest in symptom management, especially among people with cancer, came from my personal experiences with friends and family members, and from my early nursing work in oncology and palliative care. So throughout these experiences, I noticed that there was often a strong focus on scans and disease progression, but a lack of exploration of the psychosocial and/or spiritual aspects of navigating serious illness. I wondered how to support patients and families in facing mortality and in grappling with these big existential questions that often arose. So I began my nursing research career curious about what role spirituality might play in the experience of serious illness. I've since conducted studies on the meanings of spirituality and spiritual care, both among patients and among palliative care providers. Findings have highlighted that patients with cancer often describe spirituality as a connection with something greater, such as a higher power, nature, their community, and a sense of meaning or purpose. And palliative care providers, including nurses, social workers, and chaplains, have conceptualized spiritual care as encompassing building authentic interpersonal connections with patients and families, creating intentional space for patients and families to express spiritual needs, and actively supporting patients and families in their process with spirituality. My research is also focused on understanding the impact of spirituality on pain and other symptoms among people with cancer. And findings offer novel insights into the supportive role of spirituality for some people when facing cancer and cancer-related symptoms. And they highlight the need to integrate spirituality as part of a larger symptom management plan. So more recently, I've begun exploring interventions that might help strengthen spirituality and address these multiple co-occurring symptoms that often happen among people with serious illness. I've become especially interested in exploring psilocybin-assisted therapy, or PAT, for this purpose. And this is a unique intervention with initial evidence for reducing suffering associated with serious illness. And it's been studied among carefully screened samples of adults, mostly folks with cancer. So psilocybin-assisted therapy involves experiences with the classic psychedelic psilocybin in carefully crafted environments with therapeutic support. And my hope moving forward is to examine the impact of PAT on relevant nursing outcomes using a health equity lens, and to see how this intervention might help support folks with serious illness. So overall, my research addresses suffering through exploring how spirituality and spiritual care might support folks facing illness and its related symptoms, and by beginning to examine interventions that might help bolster spirituality in the context of serious illness.
Thanks, Dr. Miller. Dr. Montgomery, can you tell us about your work and how it addresses illness-related suffering?
Yes, thank you. Like Dr. Miller, my initial interests in symptom assessment and management in children and adolescents living with cancer stemmed from my clinical practice experience. Before pursuing a career as an academic researcher, I practiced as a clinical nurse specialist in pediatric oncology for 12 years. And in that time, I witnessed firsthand the suffering that children experienced from cancer and their related symptoms, especially at end of life. I saw individual differences in children's symptom experiences, with some children experiencing a greater burden from symptoms than others. And additionally, at that time, clinicians like nurses and physicians often relied on parents and our own observations rather than documenting the child's own self-report to conduct our symptom assessment. So as a clinician and graduate student, I found little science to explain my clinical observations and was left with unanswered questions. Like, why do children who have the same cancer and receive the same cancer treatment have drastically different symptom experiences and associated suffering? And what can we do to prevent or reduce that symptom burden? So over the past several years, I've conducted studies focused on illuminating children's and adolescent symptoms through their voices during different stages of cancer and treatment. In my initial work, I studied patients living with advanced cancer or cancer that has relapsed, progressed, or is refractory to treatment, and patients who are at end of life. Using electronic data collection techniques, we asked children and adolescents to report their symptoms every 2 weeks while being treated for advanced cancer. Results of these early studies highlighted the substantial and persistent suffering from symptoms of pain, fatigue, nausea, sleep disturbance, sadness, and worry. And these studies are important not only because they identify commonly occurring symptoms experienced by children and adolescents with advanced cancer, but they also show it's feasible to collect information about symptoms directly from the patient in and outside the home setting, and for long periods of time, like well over a year. And this research begins to address one of my unanswered questions, like, why do children who have the same cancer and receive the same cancer treatment have drastically different symptom burden and experiences, by describing the patient-reported symptom experiences across different types of patients receiving similar treatments for advanced disease. And the results of my early work continue to fuel my passion to further understand why those differences exist and what we can do to prevent or reduce that symptom burden. We hope to use these types of longitudinal study designs in a larger group of children and adolescents with advanced cancer to identify potential subgroups of patients who experience a higher burden of symptoms compared to others, and determine if those children share any certain characteristics that can facilitate screening and personalized symptom assessment and management. Also in pediatric oncology, children, their caregivers, and their healthcare team are all involved in symptom assessment, often because of the age of the child. And because clinicians often still over-rely on caregivers to assess the patient's symptoms in the clinical setting, I've conducted studies to explore factors that may explain why dyads have higher levels of agreement or disagreement in their perception of the child's symptoms. My research has demonstrated significant disagreement in the report of physical and psychological symptoms, like sadness, by children and their caregivers. So naturally, I was curious about why some child caregiver dyads had a higher level of agreement about the child's symptoms compared to others. And that curiosity led me to conduct a follow-up qualitative study to understand how the nuanced relationships between children and their caregivers may influence the level of agreement in their symptom reports. We found that child caregiver communication and family relationships to be important variables that correspond with children's willingness to share information about their symptoms with their caregivers. So now we are examining those variables in a multi-site quantitative study with 75 child caregiver dyads. And this research helps to address, in parallel with my other work, one of my unanswered questions. What can we do to prevent or reduce that symptom burden? We hope to support child caregiver dyads alongside clinicians to talk about the symptoms the child is experiencing and how we should manage those symptoms in order to reduce suffering.
Well, Dr. Montgomery, I think you and I have walked similar paths. My interest in symptom management also arose from my practice experience as an oncology nurse, but in the care of adults. As a new nurse, I worked with people living with cancer and at the end of life across hospital, clinic, and home settings. And in all of those places, I saw people suffering with unrelieved pain. At that time, and still now, perhaps even more so, healthcare providers were worried about prescribing pain medications, and patients were afraid of taking them. They had fears about addiction and other potential side effects of strong pain medications, and they didn't like the way those medications made them feel. But unrelieved pain disrupted their ability to enjoy life, and that created emotional suffering and distress for both patients and their families. I felt helpless watching their suffering. I needed to be able to do something to help. And that led me to become a nurse scientist and study cancer pain management. I have focused much of my work on using non-pharmacologic strategies to manage pain. Often these have been cognitive behavioral strategies, things like relaxation, distraction, mental imagery, or self-hypnosis that change the way a person perceives and interprets pain. These strategies can be used without medications when pain is mild or with medications when pain is moderate or severe. Initially, my research focused on controlling pain, but I eventually expanded to focus on symptom clusters, which are groups of co-occurring symptoms that are related to each other, like co-occurring pain, fatigue, and sleep disturbance. We've evaluated biological mechanisms of stress and inflammation that might explain why those three symptoms frequently co-occur, and we've tested strategies that reduce stress as a way to decrease severity and bother from this symptom cluster. Most recently, I've been interested in understanding patients' individual experiences and reports of which symptoms co-occur and how they relate to one another. I've been collecting this information through patient report. I think this provides really important information to drive practice. If we know that one symptom triggers two or three others, we can try to identify a symptom management strategy, non-pharmacologic or medicine, to treat that first symptom and perhaps prevent or minimize the other downstream symptoms. And this is important because people facing cancer, especially those with advanced disease and lots of symptoms, can be easily overwhelmed with everything that they're asked to do to manage their condition. So I hope to reduce suffering by making it easier to control multiple co-occurring symptoms. Dr. Bacanic, your work addresses a different aspect of palliative care. Can you tell us about it?
Yes, thank you. A different aspect of palliative care, but overall my work is still about reducing suffering in people facing acute or chronic illness. So this image on the screen, I feel represents my research in a few ways. I started my career as a critical care nurse, and in critical care, we use all kinds of machines, treatment devices, and overall many wires, as you can see here, to keep patients alive. And unfortunately, there are situations in which we ask surrogate decision makers, who are family members or friends of the patient, to make a decision whether to continue such treatments, devices, and wires with an uncertain future of what this looks like, and if recovery is even possible. The alternative is to discontinue treatment, knowing that that means the patient will die. And as a nurse, I was surprised first by how often we ask surrogate decision makers to make those decisions, and even that we were even asking them to make such a profound, devastating question that is a question of life or death. And you can kind of see the binary here of one side or the other. So surrogates suffer in making those decisions, as you can imagine. And patients suffer as they are living with machines and treatments that replace the function of all their organs that have failed. And potentially this is not the quality of life they would have wanted. So as a nurse and as an advocate, I thought this was a situation I wanted to devote my career to trying to improve. And so the way that I'm working to improve these situations is to not focus on those treatments and those wires, but to focus on the patients and surrogates. My work right now centers on improving communication between clinicians and surrogates during those decision-making conversations. I'm particularly interested in how clinicians can better involve surrogates in the conversations so that their voices are heard, and hopefully patients receive care that's aligned with their goals, values, and preferences. I know that making these decisions on behalf of loved ones will never be easy, but I'm hopeful that by improving conversations and surrogate involvement in the conversations, I can reduce suffering of patients and suffering of surrogates making those decisions.
Well, thank you so much to each of you for giving us that background and sharing your grounding in relieving suffering. I think our audience will be most interested in learning what's new in the area of symptom science and palliative care, in your research specifically and in the broader field. Can you each tell me something about, or something that you've recently learned in your research that you think is exciting or important? Let's start with Dr. Pekanik.
So what I do in my work is I try to identify those tiny differences in speech that tend to actually have really big consequences in the conversation. So as part of guidelines, clinicians are told to start the conversation by asking what the surrogate decision maker knows to try and start on the same page and fill in any gaps in knowledge. What I found is that how clinicians ask the question is important. So when clinicians ask what the surrogate has heard or what they know, surrogates respond with everything they have heard and everything that they know. So the patient's not urinating, they're having difficulty taking them off sedation, they're not waking up, but we don't really get to know if the surrogate knows what any of those things mean. Instead, if a clinician asks what the surrogate understands, surrogates tend to respond with their big picture understanding of the situation. So I think it's both important and exciting, because if we just make that small change in the question, we could have a much better discussion of the surrogate's understanding.
So the subtle difference between asking what the person knows and what they understand perhaps opens a door for the clinician to clarify information that'll help the surrogate in making a decision. Is that right?
Yeah, I think clarifying information is part of it, but I think it's also about having a more meaningful conversation. So surrogates can talk for 5 to 10 minutes about everything they've heard, but if we don't know whether they really understand what that means, is that a good use of anybody's time? So in my 10 years of studying these conversations, they have gotten longer, and we also need to be mindful of asking questions that will provide the most meaningful dialogue.
Dr. Miller, how about you? What have you recently learned from your research that's exciting or important?
Yeah, thanks. I appreciate learning about this area of your research, Dr. Pekanik. And so I recently completed a study focused on understanding palliative care providers' levels of confidence in providing spiritual care, and then what they perceived as their needs to be able to improve their spiritual care provision. So we surveyed a sample of about 200 providers, including nurses, social workers, and chaplains. And we found that nurses and social workers were a bit less confident in their abilities to provide spiritual care, understandably, and that they desired more training and more support in this area. So participants identified needs around things like enhanced training to gain a basic understanding of spirituality, lab simulation experiences focused on responding to spiritual distress, and more spaces to practice presence, listening, and self-reflection. So these findings feel important because there's a signal that providers acknowledge the relevance of spirituality and that they have some ideas for what is needed to support them in improving spiritual care in practice. So I've begun brainstorming how I can begin to address some of these identified areas of need in future research. So look out for some updates.
That is exciting. Certainly for many years, health professionals have felt pulled between the knowledge that spirituality is important to people's health and the perception that spirituality is highly personal and perhaps none of their business. So I'm excited to hear that providers are interested in receiving training to be better at integrating spiritual issues in their care. I recently spoke with a panel of rural cancer survivors who had very mixed opinions about whether it was appropriate for their care providers to bring up spirituality. Have you been doing any research with care recipients to understand their openness to receiving spiritual care from their doctors or nurses?
Yeah, that's such a great point, and I really appreciate your bringing up this question. So in the study I just shared a moment ago, providers identified that they struggled when patients and families didn't identify as religious or when they declined to talk about spirituality more broadly. So this really is a big challenge. And in another recent study, this was a qualitative study, I asked folks with cancer what the word spirituality meant to them and how it would impact their symptom experiences. And one participant in that study said, that word just doesn't sit right with me, the word spirituality. And so I'm really glad that they still wanted to sign up and participate and that they were willing to explore these topics together. So in the interview, I asked them what word or words would they prefer to use. And so they wanted to talk with me about things like what was most important to them and what made their life meaningful. So we talked about things like their connection with their family and their broader community. So it's clear that consent really is the basis of engaging in these conversations. So if patients don't like the word spirituality, we'll ask if there is another word or phrase that they would rather use. And if they don't want to explore these topics at all, we respect that choice and leave the door open if they might want to talk about this later.
Great. Let's move to Dr. Montgomery.
Yeah, thank you. I'm so fascinated by the results of Dr. Miller's recent study of understanding palliative care providers' needs in order to improve their spiritual care provision. And this area of research is not only important for adult palliative care providers, but also one that's important to the field of pediatrics. To transition a bit from spiritual care, I'd like to share a bit more about the qualitative study with child caregiver dyads that I mentioned earlier. And in this study, we wanted to again explore potential factors that may explain the differing levels of agreement between children's and caregivers' symptom reports. And in the study, we found that some children were more likely to share information about how they were feeling, while other children sort of withheld that information from their caregivers. And interestingly, their preference for symptom communication and wanting to share with their caregivers was not universal across symptoms. So for example, children often shared more challenges with communicating about psychological symptoms with their caregivers, like sadness and worry, compared to physical symptoms. And although it might seem intuitive that communication is an important aspect of symptom assessment and management, there's actually little evidence of its role. So with this finding, I collaborated with a colleague to conduct a follow-up multi-site study to establish new quantitative evidence of the relationship between child caregiver communication and the level of agreement in child caregiver reporting for the most commonly experienced symptoms during cancer treatment. I'm excited to think creatively about how to design interventions to support child caregiver communication in a variety of ways to promote symptom assessment and management.
That sounds quite novel. We heard from Dr. Miller about using preferred words and from Dr. Perkanik about how little changes in speech can have a big impact on understanding in the communication exchange. Do you have any ideas about what strategies you might use in an intervention to support child caregiver communication about symptoms?
Yeah, this is a really great question. One of my favorite parts of sort of being a scientist is brainstorming with fellow scientists, clinicians, and patients and families about solutions to new and emerging challenges in clinical care. And so we are actively working to partner with children, adolescents, and their caregivers to sort of co-design these types of strategies in order to support child caregiver symptom communication. Because we know words matter, but not every child caregiver wants to use the same words to communicate how they're feeling or what they're observing. And so we want these strategies to be flexible to accommodate a range of child caregiver preferences and to be useful across the continuum of care. So not just during the clinic visit or in the hospital, but also while they're at home. Our ultimate goal is not necessarily to achieve 100% agreement between child caregiver symptom reports, but rather ensure children and caregivers are supported in conveying the symptoms they feel and see, using individualized language with each other, and to be able to present that information to the child's healthcare team.
Well, I can add on an important finding that my team recently published, and that is also related to patient-caregiver communication. My team studied the experiences of symptom clusters in patients receiving treatment for cancer, and in this study, we asked their family caregivers, typically a spouse or an adult child, to also report their own symptoms. We did this longitudinally with patients and their caregivers reporting symptoms weekly over a period of 8 weeks. And we found that, like patients, caregivers also experienced symptoms in clusters, often combinations of fatigue, sleep problems, and depressed or anxious mood. And together with my co-investigator, Dr. Litzelman in the School of Human Ecology, we found that patients' symptoms and caregivers' symptoms were interrelated over time. So for me, one of the key takeaways from that study is the importance of including both patients and their care partners in future symptom management research. We need to address patients' symptoms and symptom clusters to reduce caregivers' suffering, and we need to address caregivers' symptoms and symptom clusters to reduce patients' suffering. Let's start to take a look into the future. What are the major issues in your area of science that will be a focus over the next 5 to 10 years? I can say that in adult oncology, there are several new or growing areas of research that should result in meaningful changes in the next 10 or so years. I'll just mention a few. Precision health has already changed the way we identify and treat cancers through better understanding of what's happening at a molecular level. From that movement and growth in the information available to us in practice, we've also been able to identify biological mechanisms like alterations in genes that put certain individuals at risk for experiencing more or severe symptoms. And I'm hoping that in the next 10 years, that new knowledge can translate into symptom interventions that better target patients at risk for symptoms or that are able to act on the underlying cause of the symptoms. This is increasingly important because of improvements in cancer treatment. More people than ever are surviving cancer, including people with advanced disease. But that means more people are also struggling with side effects of the treatments that are keeping their cancers under control. So survivorship programs that help patients and families to understand and adjust to their condition and control symptoms and side effects are critical for future research to assure that quality of life is preserved. And for better or worse, the opioid crisis here in the US is renewing interest in non-pharmacologic pain and symptom management interventions. So we need to better understand individual biologic, sociological, psychological, and spiritual factors that contribute to the experience of symptoms, symptom relationships, and importantly, to the success of non-pharmacologic interventions in minimizing or eliminating the severity and distress of multiple co-occurring symptoms. Dr. Montgomery, what would you add to this list?
Yeah, a major longstanding issue in pediatric oncology, so looking at sort of the other end of the lifespan, is the historical underrepresentation of the child's voice in symptom reporting during cancer treatment. This is definitely true compared to adults who are treated for cancer. This is especially the case when children are treated on a clinical trial. And recently, the Food and Drug Administration has established new regulations to use patient-reported outcomes sort of to understand the toxicity and tolerability of cancer treatments. And we've made such good progress in improving clinical outcomes and overall survival for many pediatric cancers. We're now focusing our attention on maintaining those outcomes while minimizing the impacts of therapy felt by the patient. And by including patient-reported outcomes in clinical trials, we can ask questions like, does treatment A result in less toxicity and better quality of life than treatment B? So I'm excited to see how that might transform future therapies for children diagnosed with cancer and being treated for cancer, as well as how we're able to support children for maintaining their quality of life during cancer treatment. Another major issue in pediatrics is the limited tools we have to assess symptoms from the perspectives of very young children. This contributes to the problem of sort of the lack of a child's voice when obtaining information about their symptoms. Most of our symptom assessment tools can be used in children 8 years of age and older. And leading researchers in the field have been working to develop valid and reliable tools to measure symptoms in children as young as 4. But unique challenges exist because of the child's developmental level and ability to perceive and communicate their symptoms. This challenge may require us to respond with less traditional formats like drawing to support children in reporting their symptom experiences. So I'm excited about the impact of this work and being able to include very young children in our future studies to identify and illuminate their voices.
Thanks, Dr. Montgomery. Dr. Miller, what do you see coming down the road in the next 5 to 10 years in your area of symptom science and palliative care?
Yeah, I appreciate the opportunity to look into the future. So a major issue that's been on my mind is around integration of psychedelic-assisted therapy, or PAT, into mainstream palliative care. So as I mentioned a bit earlier, PAT is an intervention that has been part of my program of research, and it involves experiences with the classic psychedelic psilocybin in carefully crafted environments with clinical support. And it's been studied among adults with serious illness with positive findings for reductions in depression, anxiety, demoralization, and increases in things like spiritual well-being and quality of life. So as this intervention moves through current phase 3 trials and into possible federal approval within the next few years, there's a lot of concern around what types of containers are needed to maintain the safety and efficacy that we're seeing in these trials. There's also concern around who will be able to provide the assisted therapy part, which includes preparation, support during the psychedelic session, and post-session integration. So I and others in this field believe that nurses are very well positioned to provide this care. And in fact, nurses often already are providing this care in many of the ongoing trials. So over the next 5 to 10 years, I'm envisioning a lot of movement with research, trying to figure out the mechanisms around how this intervention works, who it works best for, and how to carefully bring it into practice. And I think nursing will play a huge role in this.
Wow, the outcomes you're interested in really fall squarely within the scope of nursing practice, protecting and optimizing health and alleviating suffering. I'm so glad that you're contributing to defining nursing's role in this novel therapy. Dr. Pekanik, can you tell us what you see that will influence palliative care communication research in the next 5 to 10 years?
Yes, thank you. And I've heard you all talk about quality of life. And certainly in palliative care communication, it's about making sure people are living a life that they feel is quality. And so I would say there are developments in our understanding of human consciousness that I personally do not study, but I follow because there are major implications for how clinicians talk about and frame different health states in decision making. So for example, practice guidelines have suggested saying chronic vegetative states instead of permanent vegetative states. And they want to avoid framing universally poor prognosis for patients with disorders of consciousness. So it'll be interesting to see how communication changes. Even now, it seems clinicians struggle in their communication about what would happen if a patient continues treatment. Clinicians tend to speak very clearly about what hospice looks like. We know what that looks like, but often it's presented as a binary choice. So what does pursuing treatment look like? And for patients who are unresponsive and not meaningful interacting with their environment, what does that future look like? And do we even know? So as we learn more about consciousness of patients in those situations, our communication of our certainty or maybe even our uncertainty will need to change.
That is fascinating, really opening up a black box. And I can imagine that will have significant implications for what clinicians communicate and how it will influence decision-making in palliative care settings like the ICU. It's clear that there are many important directions for future research. What challenges or barriers currently exist that could prevent those important advances from happening in your own research or in the field as a whole? Let's start with Dr. Montgomery.
Research is always ripe with challenges, which can be frustrating at times, but does keep things interesting. So one unexpected challenge that I faced early in my research is concern from institutional review boards, also called IRBs, regarding the potential for participant burden. For example, in one of my first studies where I proposed collecting symptom data from children and adolescents throughout their advanced cancer treatment, including for some during end of life, the IRB was concerned about the potential for participant burden. Because of my clinical background caring for children with cancer, including those treated on phase 1 trials, I didn't consider my own bias in assuming the study wouldn't be burdensome to them. At the same time, I think some IRBs may heighten their protections for study samples that include children who may be at end of life. And rightfully so, given the responsibility of researchers and IRBs to protect human subjects. In my pediatric palliative care researcher community, I found that this challenge was actually not unique to me or my work, but rather one felt by many researchers conducting pediatric palliative care research. In response, we wrote a paper that proposed a hypothetical research study and obtained different and important perspectives, including pediatric palliative care researchers, an IRB specialist, and a parent. And over time, I've seen progress with this particular challenge. I attribute that progress to researchers sharing their experiences and engaging with IRBs in thoughtful dialogue to ensure studies that both protect participants, but also advance science.
Dr. Pekanik, I can imagine that you have similar experiences in conducting research with patients and families in the ICU that are really vulnerable or at a vulnerable time in people's lives.
Yes. And for me, I've had similar experiences, not necessarily with the IRB, but with physicians and especially nurses. As a nurse myself, I understand the call to be an advocate for patients as well as families. And sometimes I've experienced nurses not wanting me to talk to families about participating in a research study because they know they're going through a really tough time and they're trying to protect them. But a lot of times, families participate in my studies because they want to help and they want to make positive changes in the decision-making process. So I think it's always a balance between trying to protect patients and families, but also allowing them the autonomy to decide if being in a research study is going to be too much or if it's something that they want to do. I know for me, about half of the people I talk to do not want to be in a research study, and that's okay.
Dr. Miller, I know you're interested in broadening your reach. Can you talk about that challenge?
Yes, absolutely. So, my work with psychedelic assisted therapy, or PAT, has really opened my eyes to the need for intentional efforts to address health equity. When I initially learned about the PAT intervention, I was so excited and I went into the literature and conducted a literature review to synthesize evidence around its safety and its efficacy among people with cancer. And I was surprised to find very positive outcomes for PAT, as I mentioned earlier, around things like high levels of safety and relevant nursing outcomes like depression, anxiety, spiritual well-being, and quality of life. So another key finding of the review was that most patients across samples and across studies were made up of participants who were predominantly white and who had relatively high levels of education. So given what we know about health inequities and access to care in general, this raised an important concern for me and felt like something that could not be ignored as this field of research progresses. So I'm now beginning a qualitative study to understand perceptions and attitudes around PAT among people with cancer who have been underrepresented in prior research. And I'm excited that this work will uplift the voices of people who have been less included in prior research, and it will begin to explore what might help folks feel more comfortable in participating moving forward. So these findings will inform future steps for my own research in this area and hopefully for the larger field as well. And while I'm excited about this work, it has not come without its own challenges, such as efforts to secure funding to support the study and logistics around recruiting this diverse sample. But we're continuing to push forward despite these challenges, and we're in the very early stages of this study, but I've already learned a ton.
That's great. While the challenges we face in our research are real, I know that we're all deeply committed to this work, and we chose to do our research at the University of Wisconsin for a reason. One of the longest and deepest traditions at the University of Wisconsin-Madison is the Wisconsin idea. That's the belief that what we do here at the University of Wisconsin, the education we provide, the innovations we create, and the knowledge we develop through research should not just stay here on the campus, but should better the lives of the people of Wisconsin and beyond. Can any of you talk about unique issues or problems the people of Wisconsin face with respect to symptom science and palliative care? And how does your research reflect the Wisconsin idea?
Sure. So I did a survey of residents in the state of Wisconsin and found that over 40% have made a major medical treatment decision for themselves or someone else as a surrogate decision maker. And as part of that survey, people had some space to describe their experiences. But I had so many people attach notebook pages and call me to tell me about their experiences and how much they impacted them, sometimes even when the decision was made over 20 years ago. And in Wisconsin in particular, due to our location, a lot of folks don't really have access to facilities. So if they decided to continue treatment, their loved one might be hours away from them. So I know that this is an issue that affects people in Wisconsin. And currently, I'm working with a community advisory board to see what they think about how clinicians talk to them in these situations. Do they prefer that they ask this question over that question? Is one easier to understand or to answer? So I'm trying to make sure that the intervention I will eventually design is going to work and help surrogate decision makers in making these decisions in Wisconsin and beyond.
That's interesting. I also did a survey of Wisconsinites last year. As we all know, much of Wisconsin is rural. About 1/3 of our state's population is rural, living at least 15 miles from a hospital and much farther distances from specialist medical care and related resources. I asked rural cancer survivors about their symptom experiences and knowledge of non-pharmacologic self-management strategies. On average, people reported experiencing 9 different symptoms associated with their cancer or its treatment. The most common were fatigue, pain, difficulty sleeping, and worrying. We shared a list of 27 different evidence-based symptom self-management strategies, including physical, behavioral, cognitive, and complementary therapies. 39% of the sample had learned about using physical activity to control their symptoms, but less than 1/3 had learned about any of the other 26 strategies. So we learned there's a big gap in getting needed symptom management support to rural Wisconsinites facing cancer. We're working on using their feedback to modify a nurse-delivered symptom management program for cancer survivors in rural communities. Well, this has been a really interesting discussion, but we are starting to run down on time. So my final question today is for all of you. What is one takeaway that you'd like to share with listeners about your work in symptom science and palliative care?
Oh, I love this question to end on. So for me, my response would be that children and adolescents want to be asked about their experiences and want their responses to be heard. It's really that simple. And their experience with living with cancer is uniquely theirs, and only they know how their body and mind is responding to the cancer and its treatment. And we can really partner with children and adolescents and their caregivers, as well as their clinicians, to assess and manage symptoms to relieve suffering.
Dr. Montgomery, I second that comment about partnering with caregivers and including them as partners in symptom management. I would also emphasize that to meet the needs of people living with cancer as a chronic condition, we need to apply the principles of precision health to symptoms and symptom management strategies. Treatment strategies that work for one person may not work for another, and the experience of multiple symptoms is very complex. Even when people have the same co-occurring symptoms, the way those symptoms are related to each other, which comes on first, how they worsen or overshadow other symptoms, and their meaning can be very different for each individual. And that information is critical to selecting the most appropriate and beneficial symptom management strategies.
I think those are both such important ideas. I'd like to jump in and add kind of more of a research focused answer that I think we need to think about communication differently. I think guidelines are so vague. We cannot just tell clinicians to solicit patient values during conversations and expect them to know exactly the best way to do that, or how to best incorporate the information that surrogates give them about the patient's values into the decision-making conversation. So we need to give clinicians better guidance on what to say, but also remind them that they need to listen in order to have meaningful conversations.
I so appreciate hearing all of your responses and being here together. So I would like to highlight that spirituality is often a core part of palliative care and a present part of many folks' symptom experiences. And spirituality is a unique concept, and that word might or might not resonate for everyone. So we can all begin to explore aspects like what makes our lives most meaningful. So if you're a student, an alum, or another community member who might be curious to learn more about symptom science, spirituality, and/or psychedelic-assisted therapy, I would encourage you to follow that curiosity. There is a lot of work to be done in each of these areas.
That is great advice, Dr. Miller. We need more nurse scientists to help us alleviate suffering. Well, thank you all for taking the time to join this Red Talk today, and thank you to our online audience. As always, we're grateful for support from the School of Nursing, our research teams, funders, and study participants. Without the support, our work would not be possible. Feel free to share this Red Talk with colleagues you think might also enjoy it. And if you're interested in pursuing a degree or finding a faculty position, follow our link to the UW-Madison School of Nursing. Take care, and on Wisconsin.